Welcome, everyone, to the Living Well with a Blood Cancer virtual conference. The Leukemia and Lymphoma Society of Canada is proud to introduce this presentation titled Reconnecting, Intimacy and Sexuality During and After a Blood Cancer Experience. In this 60-minute live webcast, Reanne Booker will explore the emotional, physical, and relational changes that may arise during and after treatment. Before we begin, let me introduce myself. My name is Desiree Naylor, and I am a community service lead here at the Leukemia and Lymphoma Society of Canada. I'll be the moderator of this online event. We invite you to type your questions and comments in the Q&A box of your Zoom webinar panel. And LLSC staff will monitor the questions, and I will read some of your questions at the end of the presentation. I'd like to remind everyone that due to the large number of participants and limited time, we may not be able to answer all the questions. Please note that Reanne cannot answer specific questions about a person's health, history, or status. Lastly, today's presentation will be recorded, so you can re-watch it again on our website. Next slide. As we come together from across Canada, we recognize that we are on lands of many Indigenous nations. We honor the First Nations, Inuit, and Métis peoples whose deep connections to these lands enrich our community. We value Indigenous voices and are working to ensure they are truly represented in our leadership and staff. At the Leukemia and Lymphoma Society of Canada, our commitment to diversity, inclusion, and belonging and health equity guides how we work to support and uplift everyone affected by blood cancers. Are you looking for specific programs or resources but not sure where to find them? We are here to help. You can connect with the community service lead in your area to receive personalized assistance and get connected to resources in your area. We can listen attentively with compassion to the challenges you are facing, point you to information specific to your type of blood cancer or treatment, help you get organized to manage and take charge of your care, and identify services that would be beneficial to you. Next slide. We know that having a blood cancer diagnosis can be very overwhelming, but know that you are not alone. There is a blood cancer community that is here to support you every step of the way. As mentioned earlier, you can access one-on-one support to help you navigate the blood cancer experience. Next slide. On our website, you will find tailored information and resources, including those specific to taking care of your body. Our goal is to better serve the community and offer an improved experience. Next slide. The information and resources on our website are tailored and presented in multimedia formats to address the variety of needs and preferences. This includes fact sheets and booklets, podcasts from our channel called The Blood Cancer Experience. We have information and resources to watch, like previous webcasts on blood cancer and sexuality, what you need to know. You can visit bloodcancers.ca to read, listen, and watch all of these great resources. Next slide. You are not alone. Sometimes you may feel completely alone and maybe even misunderstood by your family and friends during your cancer experience. When it happens, it can feel unsettling and isolating, but it's understandable. For those days, the First Connection program can help connect you with a trained peer volunteer who understands the emotional, physical, and relational changes that may arise during and after treatment. It is now time to introduce today's speaker, Reanne Booker. Reanne is an oncology and palliative care nurse practitioner with more than 25 years' experience in cancer care. She currently works at the Arthur J. E. Child Comprehensive Cancer Center as a nurse practitioner supporting multiple myeloma patients. Her clinical and research interests include integrating palliative care and oncology, symptom and management and quality of life, sexuality and cancer, medical cancer cannabis and care, virtual cancer care, and health equality in cancer care. Reanne is the former president of the Canadian Association of Nurses in Oncology. Thank you so much for being here today, Reanne.
Well, thanks, Desiree. And sorry about the slides. They seem to have a mind of their own, and they're advancing without me doing anything. And so we'll see. Hopefully, this won't be an ongoing challenge. But technology and I don't always get along. So as Desiree mentioned, we are going to talk today about intimacy and sexuality during and after a blood cancer experience. And I wanted to go through with you today. First of all, I have no relevant conflicts of interest to disclose. I've received funding in the past for my PhD studies from governmental organizations and nonprofit organizations, but no industry. Um, Slides are doing weird things, Desiree. I don't know what's going on. Okay, there we go. And of course, as Desiree mentioned, this presentation is intended for educational purposes only and not medical advice. So please talk to your healthcare provider if you have questions about what I discuss, but before you make any changes. So today I want to talk about the potential impact of cancer and its treatment on sexual health and intimacy, focusing on blood cancers, of course, and then to discuss strategies to help optimize sexual health and intimacy after a cancer diagnosis. And so sexuality is a very broad term, and this is the World Health Organization definition, one aspect of it, but just to note that it's a central aspect of being human throughout life. And it's not just about sexual function or sexual intercourse, it's more than that. It's really about, gender identities, roles, sex, sexual orientation, pleasure, intimacy, reproduction, and a whole lot more. But just to make the point again that sexual function is one part of it, and I will spend some time talking about that today, but it's not the only part. And again, I love this quote that was in a paper I read that said, "Sex is something we do, and sexuality is something we are." So when I first started in cancer care way back in, oh gosh, I think it was 2000, I worked in the GU medical oncology clinic. So we asked patients about sexual function and issues like that all the time. It was just part of our routine care. And then I started working in hematology and found that we didn't ask people as often. It wasn't a routine part of their care. And so I started asking patients and found that the patients with blood cancers had just as many issues and concerns, and they were not being addressed. But what I discovered pretty early on is that, again, sexuality being this broad concept can be really impacted by a multitude of factors, some of which may precede or come before the cancer diagnosis. And then some, the factors there on the right side of the slide, are things that the cancer treatment can impact sexuality in that way. So there might be other medical conditions, medications related to those other medical conditions, age, previous experiences, partner spouse issues, culture and religious influences, and then a whole other array of things that come with the cancer diagnosis and treatment. And the sexual function piece, we know that sexual function relies on nervous or nerves, vascular blood vessels and blood flow, and endocrine or hormone system function. And then, of course, the brain and the psychological aspect is very important as well. And just to make the point that changes in sexuality can occur due to normal aging and can occur with other medical conditions and treatments as well. So diabetes, heart disease, and those kinds of things. And thinking about sexuality and a study we did a number of years back with blood cancer patients, one patient said, I don't think that I would want to be told immediately right at diagnosis, you have cancer. Hey, how's your sex life? And he said that wouldn't be appropriate, but there can be some really important considerations early on at time of diagnosis. So things like fertility preservation, we need to talk about that before treatment even starts, ideally. And then during treatment, again, some people might not feel that that's a priority, but other people might want to really preserve that physical and emotional intimacy during treatment. And then there can be, in that context, some very relevant considerations in terms of safe sexual practices, and I'll get into that a little bit later. And then in our clinic, we used to have a sexual health clinic at our cancer center for about 3 years before we lost funding. Most of the patients that were referred to our clinic were in the recovery and survivorship phase. And again, that was wonderful to see so many referrals. We ended up having a wait list because there were so many people being referred. But we did see people years past their diagnosis, and often it would have been better if we saw them early because we could have prevented a lot of the distress that occurred in the patients. And then again, another time where people might not quite think that sexuality and sexual function is relevant is during advanced disease and at end of life. And again, it just depends on the individual. But I did get a request from one of the local hospices a couple years back to do an in-service at the hospice for the hospice staff about sexuality and disease and illness. And they had a staff member had walked in on a couple engaging in sexual activity in one of the hospice rooms, and they wanted to know, what do we do? Do we put a sock on the door? Do we put a sign on the door? And as all of you probably know, we're not great in the hospital settings or healthcare system about maintaining and helping to preserve privacy and intimacy all the time. So there are things we can do to help people. And again, it might not be sexual activity at end of life, but that physical and emotional intimacy for many people is still very, very important important. And there are things we can do to preserve that and make sure that patients are maintaining those connections. And then in our clinic, we saw a wide array of different concerns. The most common concerns we saw for females was changes in the vulvovaginal health. So that would be most often due to reduced estrogen as a consequence of chemo, total body irradiation. Sometimes we saw graft versus host disease in the vulvovaginal tissues as well. But these changes can often lead to profound dryness and really friable or frail vaginal tissues that can make sexual activity very painful. There can be bleeding with sexual activity, and that pain with sexual activity can then impact orgasm, impact desire and interest. Of course, the fertility piece is very important, and then the psychosocial aspect as well. So the impact on relationships, body image, self-esteem, those are all really important aspects as well. And we know from research that's been done already that surgery, radiation, chemo, hormone therapy can definitely impact sexuality and sexual function. We don't know as much about the newer immuno-oncology agents and cellular therapies such as bispecific antibodies and CAR T cell therapy. And so for women, again, that loss of estrogen, be it a consequence of chemo, radiation, or potentially even just normal aging, this can be very distressing. And we know that treatment-induced, chemotherapy-induced menopause is often a lot more abrupt and intense than natural menopause. And this can be very distressing. And in young breast cancer patients, they found that this was one of the most distressing aspects of treatment that patients experienced. And so again, that loss of estrogen, particularly in the vulvovaginal tissues, can lead to dryness, irritation, burning, pain. There can also be changes because of that loss of estrogen in the vaginal pH that can then predispose somebody to recurrent urinary tract infections. And so we can see all these different changes that happen. The good news is that there are things we can do to help manage, prevent ideally, but also manage these changes if they do arise. And again, to make the point that unlike the vasomotor symptoms like hot flashes that come with menopause, those tend to subside within a few years of the onset of menopause. The vulvovaginal tissue changes do not improve. They do not subside unless we do something about it. And then for men, again, we saw a wide array of concerns that male patients had. The most prominent and most common, I would say, would be erectile changes, so difficulties with erectile function. Less commonly, changes in ejaculation, changes in orgasm. Again, that can be associated with the changes in erection, but you don't need an erection to have orgasm. And then, like females, the impaired or altered fertility, potentially graft versus host disease of penile tissues, not as well understood as some of the other sites of graft versus host disease. And then psychosocial, very important as well. And so, again, we know that after transplant, hematopoietic stem cell transplantation, more than 50% of male survivors reported changes in sexual function. Most often it was erectile dysfunction, a range between 12 and 78%, and loss of sexual interest and decreased libido. And sometimes that's associated with reductions in testosterone. Sometimes that improves after transplant. But again, this is something that we can investigate. If someone has a low testosterone, we can help with that. And changes in desire, again, this can happen as we age. It can happen with any of the treatments, treatment modalities for cancer. And historically, this was the sexual response cycle that was described by Masters and Johnson many, many years ago. And it was almost a linear process where there was desire, arousal, excitement, orgasm, and kind of one, step of that cycle preceded the next. And we know from newer research that that's not always the case, that it doesn't always proceed in this stepwise linear fashion, that somebody can engage in a sexual encounter, even if they don't have that spontaneous desire or spontaneous interest for sexual activity, that might not be there. So somebody might not necessarily be in the mood or want to participate in sexual activity, but once they become physically intimate with their partner, maybe a massage or dancing or cuddling, then that desire can come after some of the sexual touching and different things like that. So you don't need to have that spontaneous desire in order to go on and have a satisfying sexual encounter. And again, all those steps in the sexual response cycle need not be experienced for it to be a very satisfying or pleasurable experience for partners. And again, people have different motivators for sexual activity. Sometimes it's pleasure, sometimes it's closeness with the partner. So that also influences where somebody will be and what really matters to them. So as I mentioned, we saw a lot of changes in erectile function. Mostly it was difficulty achieving erections, maintaining erections, and sometimes insufficient firmness for penetrative intercourse, vaginal or anal intercourse. And for anal intercourse, there needs to be about a 30% firmer erection than is required for vaginal intercourse. So that can be quite a big concern for patients, is the changes there in erectile function. And there's, again, things we can do to help with that for sure. Mechanisms of erectile dysfunction, as we know, a lot of the different types of chemo can cause peripheral neuropathy or nerve damage that can influence erectile function. There can be changes to the vasculature or the blood vessels, and some of the anthracycline drugs we use in blood cancers certainly can cause endothelial cell damage, and that can influence erectile function. Changes in hormones, again, total body irradiation and high dose chemo can sometimes cause transient changes in hormone production, testosterone production in men. Sometimes that resolves by about 2 or 3 years post-transplant, but it doesn't always. It depends on how old the patient is and their medical conditions and overall health otherwise. And then psychological, I think, is a big piece here too. If there's been experiences where erections are challenging or not happening, and they can, it can be a self-perpetuating cycle where this thought and putting all this pressure can also adversely influence erectile function. And in most cases, what we saw in our clinic, it was a combination of many of the above. So some or all of the above. And changes in ejaculation are not as common in patients with blood cancers. We see this more in solid tumor cancers, and particularly prostate cancer, where there are, if the prostate is removed or there's changes due to radiation and chemo or hormone therapy that we use for prostate cancer. So we don't see this a lot after blood cancers, but it does happen on occasion. I have had a couple patients with dysejaculation or pain with ejaculation, and particularly one patient had total body irradiation, and there was some thought that there was some either epididymitis or irritation of the epididymis or even the urethra that was causing pain with ejaculation. And then again, less commonly in this population, but if there are prostate concerns, sometimes there can be little or no ejaculate, certainly after prostate cancer treatment, or sometimes even treatment for testicular cancers, we see this. And again, retrograde ejaculation would not be something we'd commonly see in blood cancers, but could happen with other types of cancers. Climacturia is the leakage of urine at time of ejaculation. Again, something we would see most often with prostate cancer and prostate health changes. But if any of these things are happening, these are things that we can definitely address. And changes in orgasm, again, can happen for both male and female patients. And sometimes it's decreased intensity, sometimes it's increased intensity, sometimes it's painful orgasm, and sometimes it's complete loss of orgasm. And we don't have a lot of research to figure out what's going on here and why this is happening. But in our clinic, we found that if we address some of the other changes with respect to sexual function and sexuality more broadly, that orgasm often improved. And again, you don't need an erection to have orgasm. So that's something when I talk to patients with prostate cancer, that it's something that they're not always aware of. But you don't need an erection to have orgasm. And then again, for both males and females, we see big changes in body image. There can be weight loss, weight gain, hair loss, scarring, skin changes. This was a study we did a number of years back, and I interviewed patients after stem cell transplant. And this was a male patient who was very distressed by his changes in his body image. So he said, I remember the first time I looked in the mirror when I got up to go to the bathroom, and I literally fell to my knees sobbing because I didn't recognize the person that I saw. I'm trying to fight tears off now, talking about it. I've mourned the loss of who I was. I was stronger physically. Now I'd say 90% of what I used to be. I've got a much bigger heart. Some say it's the girl blood that makes me cry so easily. So his donor was a female, so that's why he's joking about the girl blood making him cry. But just to make the point that even in male patients, and sometimes we as healthcare providers forget that this is a very significant concern for both male and female patients. And again, there are things we can do to help with this. Fertility, again, I don't really have time today to get into this, but this is something that's very, very important for patients undergoing cancer treatment. Ideally, we'd like to have fertility referrals and fertility preservation prior to starting treatment. That's not always feasible or realistic in the blood cancer population because for female fertility preservation, often if we're going to do something like an egg harvest, we need a certain platelets usually need to be higher than 50. We also need a little bit of a window of time to do the egg harvest and all of that. And sometimes that's just not realistic. With acute leukemia, we cannot wait weeks to start treatment often, and platelets can often be very low. But ideally, these conversations should happen before treatment starts. And when I first came to Calgary in 2005, I connected with our regional fertility program and set up a process where we can get same day or next day referrals because there is an urgency for patients to start treatment. There are new guidelines published by the American Society of Clinical Oncology, again, making the case that we really need to be addressing this ideally before treatment starts. And for males, fertility preservation usually involves semen cryopreservation. So people can go to a lab and provide a semen sample, and that can be stored until it's ready to be used. It costs about $400 here in Calgary to do the storage or to procure the sample initially, and then about 200 per year for storage fees. And for in IVF or in vitro fertilization for females, the cost can be quite a bit higher, so 8,000 plus, depending on the fertility clinic. There are some programs within Canada that can help with the costs associated with fertility preservation. So these are both Canadian organizations that are interested in providing support, financial support for patients with cancer. And then again, we know that there can be profound relationship changes that occur, and this can be because of that stress of this very serious diagnosis. And then there's just oftentimes a very big shift in roles and what's going on with a couple. This can be difficult or challenging for people in existing relationships because suddenly this is a big change, particularly is related to physical intimacy often. And it can also be difficult for people who are embarking on new relationships or just starting to date. In our study again, we had one patient and he shared his story about how he had been diagnosed and he had a girlfriend at the time. And then when he relapsed, she decided that it was just too stressful. And so then he was back in the dating world again, and he just wasn't sure, when do I share the diagnosis that I have, and when do I, talk about my cancer history and potentially my impaired fertility. And of course, that's very individualized. And at our center, we're very fortunate. We've got great counselors, psychologists that can help patients with some of this. And we did address quite a bit of this in our clinic. But this can be very difficult for relationships, to say the least. And for partners, we don't have a lot of research in this area, but partners sometimes will be fearful about causing pain or discomfort during sexual activity. So they might be, reluctant or reticent to initiate physical activity. Sometimes they might even feel unwanted or unattractive or even rejected because there's been this change in physical affection and activity. And they don't always understand that it's related to the cancer treatment, and not a personal rejection. And then often there is this change in role from partner to caregiver. And so you put on this different hat to be caregiver, and that can really influence and impact the sexual and physically intimate relationship as well. And then sometimes partners might be worried about impending potential loss, and so they might pull back in hope in as a means to try to protect themselves. So again, this is something that we navigated quite a bit in our clinic. We had partners come in if the patient was okay with it, and we worked together with couples if that's something that they wanted to do. And also with partners, just to say that partners might also have their own changes in sexual health. So we had one couple one time and I helped the patient and we got his erectile function better. And his wife said, this is not good because I have all these issues with my sexual health. And now he's, feeling much better, but I'm not okay. So, we did in our clinic, we were able to help support both the patient and the partner. Another area that is very understudied and not enough support for, but we know about 10 to 12% of the US population identifies as LGBTQ, and the numbers would be similar here in Canada, and that these patients often don't feel safe in healthcare environments. They're not, sometimes they're misgendered, and that can be very difficult when we're looking even at blood results. I had one patient who was a trans patient who had previously been male, transitioned to female, and still all the reference ranges for blood work and a lot of the things in our system, our electronic medical record, still referred to the previous gender. So that can be quite distressing. So in healthcare, we really want to focus on equity rather than equality. So equality would be treating everybody exactly the same, but we want to make sure that people that they're having their needs met to whatever the context is. So, if we had a patient, for example, who was vision impaired, and we said, well, you know what, we give everybody this handout on cancer and treatment, but this patient who's visually impaired can't read it or see it. We're treating them equally, but not equitably. So we really need to learn more about the needs of this population and how we can better support them. And then again, as I mentioned, considerations when unwell, maybe advanced disease, or when somebody's in hospital. I've had patients ask before, and again, particularly in hospice, why do we only have single beds? Why couldn't we have double or queen beds in hospice, especially? The environment is not conducive to maintaining or preserving any kind of physical intimacy. It's difficult. And then again, if there are symptoms, pain or nausea, vomiting, diarrhea, those kinds of symptoms can really make somebody not feel like they even want to be touched, necessarily involved in any kind of physical intimacy. But again, we can help to manage these symptoms and side effects, and that can help improve how people are feeling for sure. And then, of course, there can be tubes, central lines, and people might be worried about a central line being pulled out during sexual activity. There's all kinds of different devices we can use to secure central lines to make that less likely of a possibility. But again, the hospital environment for sure, and I would extend that to hospice as well in most places, is not very conducive to preserving or maintaining physical intimacy for patients. And then thinking specifically about the adolescent and young adult population. So this definition changes, I guess, depending on jurisdiction, but most areas agree that the AYA population is somewhere between age 15 and 40 or 15 and 39. And again, that can be a time of profound change when young adults are just trying to get into careers or relationships, and this can be very difficult. And we know that there are huge unmet needs in this population in terms of, helping with contraception, infection prevention, sexual function, body image, and then helping to navigate romantic and sexual relationships. Previous research has found that between 30 and 100% of adolescents and young adult cancer survivors report changes in their sexual function. And I did a talk for the Pediatric Oncology Group of Ontario a number of years back, and it was adult survivors of pediatric cancers. And this was also very significant for them. A lot of them had loss of fertility when they were children and they were being treated, and the treatment permanently impacted their fertility. A lot still had issues with chronic graft versus host disease and those kinds of things that impacted their sexuality and their body image. And so there's more work to be done here. Some cancer centers now have embedded AYA nurse navigators to help the young adult population. We had one at our cancer center, but she left for a different position, so that we don't have somebody in that role right now, and it's a huge unmet need for sure. And so when we talk about interventions, we were very lucky in our clinic. We had, a very very biopsychosocial approach to managing changes in sexual health. So we had a psychologist embedded in the clinic. We had, on occasion, a gynae oncologist and a radiation oncologist who would come to the clinic. And I was in the clinic, so I could do order blood work or order prescriptions. We did physical exams and lots of things like that. So we were very lucky that we could address these concerns from a biopsychosocial approach, because it's not enough to just treat one piece of what's going on. We really wanted to make sure we are addressing if there's issues in the relationship or communication, different things like that, in addition to the physical changes. And this model has been adapted, I would say, more broadly in the sexual health community, in the context of cancer especially. So we know that there can be these physical or biologic changes that sometimes we need medications or different interventions to treat. But certainly interpersonal issues with relationship discord, fear of intimacy, lack of communication. There can be sociocultural issues, as I mentioned previously, with religious beliefs, cultural values, and social norms. And then certainly the psychological, so anxiety, depression, emotions, and those kinds of things, all very important when we're addressing sexual health concerns. So I would argue, and I still continue to argue, that every cancer center should have a sexual health program. There should be somebody that has expertise in this area that can see patients, and that when we set up our sexual health clinic at the cancer center, it was surprising to me that probably about 40% or so of our referrals came from the hematology and BMT clinics. And I think that some of that had to do with when I was working in those clinics before, I had dedicated time for sexual health assessment clinics. And I think if nurses and physicians know that there's a resource to refer people to, they will ask earlier and they will refer earlier, which is great. But if there aren't those services, then sometimes these questions just don't get asked because people don't know what they can do about it if there is a problem. So I am still pushing to reinstate our sexual health clinic at our cancer center. I think it's really important. But there are things we can do as well. So education about different ways to maintain intimacy. We can provide more support and assistance, and sometimes that might look like home care or other supports for the partner to retain their role as partner rather than being a caregiver all the time. I am a huge proponent of psychology and counseling. I wish psychology and counseling were part of healthcare fees and or healthcare universally provided healthcare rather than people having to have insurance or pay out of pocket for psychology and counseling. And then there's different medical interventions and pharmacologic interventions that we can also do to help. So communication, and this was great. In our clinic, we had a psychologist that often helped patients with this. And the psychologist that was in our clinic was Lauren Walker, and she's the author of this article with these suggestions. So oftentimes, even patients and partners who had been married for a very long time had not really engaged in discussion about sexual health or intimacy. It was just something that was kind of always there, and they did. And now suddenly there are big problems with what's going on, and people weren't sure how to communicate with one another. So Dr. Walker and colleagues had come up with this table here of potential questions you could ask or engage in conversation about. And again, I think a lot of this is we have to adapt because once there are changes in sexual function, it's not always a quick, easy fix. Things do get better for most patients, but sometimes they don't ever get back to the way they were before. And so sometimes it's an adaptation or change in the goal of sexual activity. It might not be sexual intercourse, it might be other ways to find intimacy and pleasure. Maybe it's cuddling, watching a movie, slow dancing in the kitchen. And we know again from research that's been done previously is that patients often wait for their partner to initiate activity, and partners often wait for the patient to initiate activity. And as a result, nobody does anything, and this this gap or this issue in the relationship can happen, and that can be very difficult. So that was a great component of our clinic where we did have the psychologists help patients with communication if that was something they were not um, well versed or experienced in. I don't know why it's animating. There we go. Improving intimacy. So again, there's a lot we can do here. I always joke about this. This is from a Cialis ad. And I always said, if they were in the same bathtub, maybe that would help improve intimacy. But just again, to make the point, it does not have to be physical intimacy. It can be emotional intimacy, sensual, or again, it can be physical intimacy. Sometimes in our clinic, we talk to patients about saying we're not going to make sexual intercourse the be all end all goal. We're going to find other goals and kind of work to achieve those. So there's all kinds of different sensual activities that people can engage in. There are special exercises that trained psychologists and counselors can help patients with. So if there is a lot of pain with sexual activity or a lot of distress in engaging in sexual activity, Sensate Focus is something that would happen over a number of weeks where it would just be working on communication and touch with the patient. And then after several weeks, there's progression to touching maybe genitals or breasts and things. And then eventually, depending on the comfort level of both the patient and the partner, there may be sexual activity as the goal, but that would be something that would be established and discussed individually with the counselor and the couple. And then desire, again, I find that if we sometimes address some of the other issues, so if we can improve painful intercourse, improve erectile function. Sometimes the desired piece comes back. But again, being aware of, even if there isn't that spontaneous desire there, there can be responsive desire. So engaging in activity might then lead to more desire and arousal. Again, a huge proponent of counseling here. Some counselors will use mindfulness-based meditation. And then I always like to look at the medication list to see if there's anything that could cause impaired desire or impact sexual function. And then we don't have great drugs to help with this, but there is a medication called flibanserin that's a serotonin subtype 1A agonist and subtype 2A antagonist, and it's approved for premenopausal women with hypoactive sexual desire disorder. Um, and that it was initially developed as an antidepressant, but found to actually help improve desire. So it can be an option, but the caveat is the approval is based on hypoactive sexual desire disorder that's not caused by a disease or medications. And in our case, in this context, it is often medications and disease that are causing the impact on sexual function. And then improving erectile function, there's a lot we can do. So I like to always try to figure out what is the reason for the erectile dysfunction. Is it hormonal? Is it nerve damage? And then that will help to guide the treatment or the interventions. And there's a lot, like I mentioned, the medications. There are external penile prostheses or strap-ons that can be used. The picture here is something called the elator. It's custom made and it helps to position the penis. It's expensive. It's about $350 US right now for the cost. And I have not had any patients personally who have used the elator, so I don't have any anecdotal feedback to let you know how it goes. Um, and then constriction rings to help keep blood in the penis. So that's something like, let's see if you can see, constriction ring that we placed at the base of the penis that helps to keep blood in the penis and can help with maintaining erections. And then vacuum erection devices, I'll get into those as well as penile injections and implants in a minute. So the phosphodiesterase type 5 or PD5 inhibitors, these are the drugs that we know, Cialis, Levitra, and oh my gosh, Cialis, Levitra, and Viagra. How could I forget Viagra? It was the first. Avanafil is another drug that is available in the States. It's not available yet in Canada. They all work very similarly. So they promote a smooth muscle relaxation in the penis and increase blood flow into the corpus cavernosum in the penis. They need to be taken prior to sexual activity, so that removes a little bit of the spontaneity sometimes that patients don't always like. You have to think about taking a drug to get an erection, and that kind of kills the mood for some people. But Cialis or tadalafil has a 5 milligram daily option that you could just take with all your other meds, and then that achieves kind of a steady state of the drug in one system. So that would mean that somebody would be kind of good to go, I guess, at any time without having to think about taking that medication 30 to 60 minutes before sexual activity. These medications can cause low blood pressure because of that smooth muscle relaxation. So if somebody is on nitroglycerin or something that might cause vasodilation or opening of the blood vessels, that can cause very serious low blood pressure. So this is something if you go to the ER with chest pain as a male, they often will ask if you're taking any of these medications before they give nitroglycerin. Um, Again, these drugs don't always work for everyone. It depends on what the reason is for the erectile issues. So if there's bad nerve damage from chemo or radiation or surgery, these drugs don't always work. If there's really low testosterone, these drugs don't always work. So that's again why that assessment piece is really critical. And the other options, and I know a lot of men cringe when we talk about intracavernosal injection therapy. So that's where we inject, it's a tiny, tiny needle, like a diabetic needle, a medication into the penile tissues, and that causes an erection and is very effective, even for neurogenic or erectile issues caused by nerve damage. So I had a clinic, I would teach men or their partners how to do the injection. We would always do the first injection in the clinic, and then and then men would go home and they or their partners would continue with injections, not more than I think 2 or 3 times a week is what the recommendations are, but very effective, especially when the other medications and things don't work. So 85 to 90% efficacy. And then transurethral therapy. So this is alprostadil or prostaglandin type medication is put into the urethra, and then it absorbs into the penile tissues. Efficacy is lower; it's about 20 to 40%. And again, I think we have more experience, at least in our clinic, with the injections and the medications than with the transurethral therapy. And then for other options, vacuum erection devices can be very effective. So they pump blood into the penis, and then typically somebody would put a constriction ring at the base of the penis. That can be very effective. So again, efficacy in the neighborhood of 90 to 100%. The blood is pumped into the penis and held there with the constriction ring. It needs to be a good quality device. So there needs to be good suction and good quality device. So this again, I would ask somebody for recommendations where to buy something like this, because they do sell certain devices like this at sex stores and things, but they're not always great quality. And then penile implants would be more of a last resort. It's a surgical procedure where there's two different types. So there's one where there's a fluid-filled reservoir that's placed in the abdomen, and a pump with a release valve that's placed in the scrotum, and then cylinders in the penis, and you can pump up to have the erection when desired. And then there can also be these semi-malleable or semi-rigid or malleable rods that are placed, and then the penis can be bent or moved into the desired position for sexual activity. And those are very effective, but that is a surgical procedure, so that is not something we would do first line. We would try other things first. And then again, ejaculatory changes we don't see very much in the hematology and post-transplant population. It's more likely to occur if there's prostate issues. But if somebody has concurrent prostate issues after a blood cancer diagnosis, this could be relevant. And so again, we educate patients about what to expect and their partners. And then if there is any concern about urine leakage at time of orgasm or ejaculation, we have different strategies. So the constriction ring can sometimes help to compress the urethra so there is less urine leakage. A condom would also prevent leakage of urine, and pelvic floor physiotherapy can be very effective as well. And then very little studies in this area on orgasm. So anecdotally, and some suggestion or some research suggests that counseling and mindfulness based meditation can help. Penile vibratory stimulation is being studied in the prostate cancer population. And then different medications, again, often we see this more often in the prostate cancer population. But really, we don't have great options right now for medications to help with orgasm. And then for females, managing vulvovaginal symptoms. So again, I want to always find out what the reason is. Very often it's loss of estrogen, either from natural menopause or treatment-induced menopause. And then there's a bunch of things we can do. So just as we would moisturize the skin of our face or our body, the vaginal tissues and vulvar tissues should be moisturized as well, particularly when there's a loss of estrogen. That can change things very significantly in the vulvovaginal tissues. And so using a vaginal moisturizer, ideally 2 to 3 times per week, and it can take 2 to 3 months before optimal benefit is seen. They have studied the use of diligent use of vaginal moisturizers and compared to the use of vaginal estrogen, and the results were not bad. Vaginal estrogen was slightly superior, but very good diligent use of vaginal moisturizers can also be very, very effective. And then lubricants would be something used to help reduce friction, either for sexual activity or pelvic exams. They will not fix or improve the health of the vaginal tissues, but they will help with the friction and pain caused by friction. Silicone-based lubricants last a bit longer. Water-based are less messy and less likely to stain sheets. We don't recommend oil-based lubricants because they can erode condoms, and that can be problematic. And so there's examples. There's so many different types. And I would say if you can get samples, sometimes clinics, we would have samples we could give to patients. I had somebody one time buy a case of Replens at Costco and tried it, and the preservative in the Replens was very irritating, so she wasn't able to continue using it. So again, finding something that works. Some people use vitamin E oil, so just puncturing the capsule with a pin or something and squeezing out the vitamin E oil and rubbing. You have to treat the vulvar tissue, so the outside of the vagina, the opening of the vagina, and inside the vagina for optimal benefit. And lubricants, again, an array of different lubricants on the market. I would say same thing is you can get samples and try them first. Some of them have, different cooling agents or heating agents or flavors and things. And those can sometimes be very irritating to the vaginal tissues. So we often recommend avoiding those additional additives. And then vaginal dilation historically was used for patients undergoing pelvic radiation for gynecological cancers. But again, in our clinic, I use vaginal dilation very often for patients who had significant vulvovaginal changes because of loss of estrogen or vaginal graft versus host disease. Our cancer center uses these hard plastic, so we can give these out to patients for free. But they're very firm and rigid. And patients have told me over the years that they prefer something that's a little more tapered and that's more pliable. These are medical grade silicone dilators. They come in different sizes and they tend to be better tolerated and easier to use. And again, vibrating wands. There was a study in the States looking at the use. They didn't call them vibrators, they called them vibrating wands. Um, and the theory was that that would help to improve blood flow to the vaginal tissues and help improve oxygenation to the tissues and improve the health of the tissues. And and so you can use a vibrator to dilate. You don't have to use the vibrator function. You can turn that off or you can use it. It might help. And again, as I mentioned, they're studying this in prostate cancer as well, penile vibratory stimulation. There's all kinds of different vibrators on the market. This one's called the Vibrator, and it can be used with a flaccid or semi-flaccid penis. So there's all kinds of different devices. This one here retails, I think, for about $17,000. It's gold plated. I don't think anybody needs that necessarily. But again, to make the point that you don't need an erection to have orgasm. The dilator, here's some instructions on how to use the dilator. This is from Memorial Sloan Kettering Cancer Center in New York City. And we liked to use the graduated dilator set, so starting small and gradually working up. And ideally, people should use dilators a couple times per week for about 10 to 15 minutes for each session. This was very helpful for a lot of our patients post stem cell or bone marrow transplant because they had abstained for sexual activity for so long that there was a lot of introital stenosis or tightness at the opening, and that could be very painful. So gradually we would have patients use these dilators. And then estrogen therapy can be very helpful in improving the health of the vulvovaginal tissues. And again, we see this in the context of postmenopausal women when they have symptoms and issues associated with menopause. We have to be careful if there's history of a hormone receptor positive cancer, like a hormone receptor positive breast cancer or gynecological cancer. And we do see sometimes patients get secondary cancers after treatment for those cancers, so we have to be careful. But the use of local vaginal estrogen is not really considered a contraindication anymore. I would still have that individualized discussion with the patient and their oncologist. But using local vaginal estrogen can be very effective at improving vulvovaginal symptoms. So this is a picture of Vagifem. It's a tablet that's inserted. And I can tell you from experience too, I've seen very nice looking vaginas with Vagifem, but the vulvar tissues, so the tissues on the outside of the vagina, I can't really see that. And the opening of the vagina don't always get treated then with the estrogen. So a vulvovaginal application of a vaginal estrogen cream of some time, again, applying on the outside tissues at the opening of the vagina and inside is really helpful. There's newer medications in Canada that have recently been approved. Intrarosa is an intravaginal DHEA, and it's gotten good reports so far in the literature. And then a selective estrogen receptor modulator called Osphena or ospemifene, again, can be used to help improve the vulvovaginal tissues. And it's an estrogen agonist antagonist. It does not seem to be causing problems in patients with hormone receptor positive breast cancers. And then Imvexxy is an estradiol insert. I don't like this. This is the marketing of, I forget which medication it was, like suggesting the vagina is old and dry like dying flowers, and that makes me mad. But anyway, that's the marketing campaign for that particular drug. And then laser therapy. So you might hear things like the Mona Lisa laser. There's lots of different clinics in Calgary, and I'm certain around Canada that offer laser therapy. So it's a fractional carbon dioxide and erbium laser usually. And the intention is that it's going to improve vaginal health by causing micro trauma to the tissues. And then that induces collagen formation, angiogenesis, so new blood vessel formation, and epithelial thickening. It can also cause vaginal scarring and pain and lacerations, and worsening potential pain with intercourse. So the studies so far have not been that compelling in terms of this as a treatment for improving vulvovaginal health. And as of right now, I would say it's very expensive as well. So I would say this is probably not the best option, but who knows, going into the future, perhaps it will be better. Pelvic floor physio, we had great pelvic floor physio that we referred patients to. So it's a physiotherapist with special training in pelvic floor physio and can be very beneficial for both male and female patients, improving vaginal tightness, increased sensation and orgasmic potential, better bladder control, and for males, improved erectile function, ejaculation control, orgasmic control and sensation, and reducing sexual pain. So again, I wish physio was covered as part of our regular health benefits because I think it's so important. And just to quickly discuss safer sex, so we do caution patients, you do not have to abstain from physical intimacy, but avoiding certain types of sexual activity. Most cancer centers say to use condoms or dental dams for about 72 hours after receiving chemo, because theoretically there can be a bit of chemo that can be in vaginal secretions or semen. Not great studies on that, so it's more theoretical, and the risk would be very low to a partner. And then when platelets are low, there's increased risk for bleeding and bruising. So engaging in very rough sex, flogging activities and things we advise against. And when white blood cell counts and neutrophils are low, there's potential for increased infection. So that would again be not a great time for anal intercourse because there could be micro tears and then bacteria could get introduced into the bloodstream and cause infection. So I had one patient one time say that they stopped sexual intercourse and even kissing for a full year after transplant because they were worried about infection, and that's not necessary. But there are some cautions just around the acute chemotherapy delivery and certainly immediately after stem cell transplant when counts are very low. And just to say, preserving intimacy, it should not always be about the physical part. The emotional and relational parts are very important as well. And there does not need to be erections. There does not need to be, if there's changes with vaginal health, that's okay too. We can still encourage people to have relational and emotional connections and non-intercourse dependent activities. And then we can adjust as needed for people who really want to get back to the physical sexual intercourse aspects. And so just to make the point again, it's very common for changes in sexuality to occur after a diagnosis of cancer for both the patient and the partner. There's lots we can do to help improve sexual function, sexual activity, sexuality. We have a lot of resources that mostly at our tertiary or our big cancer centers in the urban centers, but some rural sites would have access to. And certainly if you connect with a sexual health expert at the cancer center, they can support you through the diagnosis and following. And again, there's no right amount of desire, no perfect relationship, and no such thing as a normal sex life. I've learned that in the clinic for sure. Um, I would say don't get discouraged if something isn't working. Keep trying because there's lots of different things we can do, and we have to be creative in the clinic sometimes. But there was a lot that we could do to help improve sexual function and relational intimacy. And then I would just say keep talking to your partner, to your healthcare provider, and don't give up. There's lots we can do to help. So there's lots of resources available. I would copy and paste these links directly. If you type sex into a Google search, you can get some interesting websites. So there's lots of great resources and some LGBTQ specific resources in Canada as well. And I will stop there and happy to answer any questions that you might have.
Thank you, Rianne. Your expertise always brings such valuable insight, but to this, like a very under discussed aspect of life after a blood cancer diagnosis. So thank you so much. Um, yes, it is now time for questions and answers. If you haven't done so already, be sure to use the Q&A box in your Zoom webinar panel to type in your questions. And as we mentioned earlier, due to the large number of participants and limited time, we may not be able to answer all questions. And also important to note is that Rianne cannot answer specific questions about a person's health history or status. So let's see, let's pull up.
And I'll just say this, I put my
Yeah.
email address there in the chat because I know sometimes it can be intimidating to ask questions on the spot.
No.
So please, if people have questions, feel free to email me and I'm happy to answer them or even talk to you over the phone if that's easier.
Perfect. Oh, great question. Is Oasis still available for Arthur Child patients? So in Calgary, um,
Yep. Yeah, so Oasis is a bit different now. So previously, when we had the clinic, that was part of Oasis, and we did educational workshops. The workshops are still occurring. So there's a vaginal health workshop, and I believe there's a workshop for men as well. And that's those workshops are still occurring. There is no longer the clinic, but there is an occupational therapist who can speak to people. She often does phone consults. Um, she wouldn't be able to prescribe medications or do those kinds of interventions, but she could make a recommendation to the referring provider or the oncologist or the primary care provider as to what might be helpful in terms of medications.
Perfect. Let's see, another one. Oh, so we can still refer to Oasis, just less available.
It's just
That's
different. Yeah, yeah.
Yeah,
There's not the physical clinic anymore. So the physical exam piece, and sometimes I would do, hormone testing and blood work and different things, or, pap tests and things. We don't have that part anymore, but there is definitely the educational piece that's still available for patients.
wonderful. Um, so how do we deal with a partner's resentment over not being able to be intimate once we look better?
Yeah, you know what? That's such a common thing, and people often think it's like a broken arm. You finished your treatment, and now let's just get on with life. It's not the reality for the majority of patients in any cancer context, but certainly after treatment for a blood cancer. Counseling would be the number one recommendation there. So I would recommend individual counseling as well as couples counseling. It may be that the partner just doesn't understand that the change in sexual activity is a direct result of the treatment. So they might be taking that as personal rejection. So I would say counseling for sure would be the first recommendation I'd have for that. Yeah.
Wonderful. What about somebody who may be experiencing fatigue and motivation? What are some suggestions for them?
Sex in the morning. So, so I mean, sometimes you have to adapt. So we know, I don't know if that was a male or female question, but fatigue for sure is one of the most common symptoms and side effects associated with cancer and treatment, particularly blood cancers. And so planning around how you feel. And I know it sounds a bit silly, but sometimes people have even had to kind of schedule sex and put it in the calendar. But trying to think about when you feel your best during the day. And oftentimes it is in the morning where there might be a little bit more energy. Testosterone levels are often at their peak in the morning. And then also planning with medications. So if there's still pain going on or nausea, taking those medications at least 30 to 60 minutes before a sexual encounter can also really help with the experience. But yeah, the fatigue piece is tricky. So just trying to get creative, and sometimes different positions can also be helpful. The Canadian Cancer Society has got a great booklet on sex and cancer that even has drawings of different positions that can help with different concerns like fatigue or pain and that kind of thing.
And what would you suggest to somebody who is maybe immunocompromised?
Yeah, so I think, it's not a contraindication. So being immunocompromised puts people at higher risk for infection. So again, being very careful with a new partner or somebody whose background you don't know. So using condoms and being precautious that way. But it's not a contraindication. You can kiss, you can cuddle, you can have sexual activity. At times, again, where the platelets are very low, there's risks of bleeding. So very rough sex might not be great for that period of time. And then if neutrophils, and I'm talking about neutrophils, less than one or less than 0.5. But regular sexual activity is not off the table. It's not a contraindication, even if neutrophils are a bit low. So it's just modifying some of the sexual activity practices. But yeah, I would say don't avoid, even if you're immunocompromised, still be cuddling, kissing, and that kind of thing. It's
Mhm.
all okay.
Perfect. And I think we'll do one last question. How to connect and make friends after being widowed recently
Oh,
in their
yeah.
60s.
Yeah, that's so I don't know where this person is, but there are different support groups, I will say, online dating and online friend apps and things like that. So they work sometimes, they don't, I think it's like it'd be the same meeting somebody in real life. Potentially you could meet a great person or it could be a complete disaster. But I would check around for local support groups for somebody who's lost somebody. There can be grief support groups and different things like that. And there may be specific groups in the area. So I'm happy to look into that, Desiree. If you have the person's name and if they would like me to contact them, I can look for some local resources. And that's a great question. Before we sign off, I just did want to mention to you that particularly post-transplant for females. Sometimes females will have such severe vaginal shortening or stenosis, so tightness, and they can feel like deep penetration or penetrative intercourse is very painful. And so it used to be that we'd recommend placing towels to control depth of penetration, but there are these devices, I guess, called the O-nut. It's medical grade silicone that go on the base of the partner's penis. They're very flexible, and you can stack them. And that's a way to control depth of penetration so that intercourse is not as painful, because a lot of women will mention that there's pain with intercourse and collision dyspareunia, where it feels like something is bumping, the penis is bumping up against something. And so this can really help to control collision dyspareunia and pain with penetration. Um, so I forgot to mention that. I just saw it sitting there, so I wanted to add that in.
Oh, perfect. Well, I thank you for that. And I thank you for answering all of the questions that came in. Again, your insight continues to make such an impact within the blood cancer community. And hopefully, today's session helps create a space for more open, informed, and supportive discussions about sexual health and quality of life after a blood cancer diagnosis. So I'm just gonna let's say, see if I can do the slides. Perfect. And there's still time to join us later today for Beyond Tired, Understanding and Managing Cancer-Related Fatigue Through Physical Activity. And every day after is a research study dedicated to understanding what life looks like after a blood cancer diagnosis. And we invite you to take the survey to bring awareness about the quality of life by Canadians diagnosed with a blood cancer. We'd also like to thank Johnson& and Johnson, Jazz Pharmaceuticals, GSK, Amgen, and Kiowa Kirin for their support in making this event happen and possible. And please remember that we are here to help you. You can reach us by email, by visiting our website, bloodcancers.ca, or by calling us toll free. Please note that a short survey will be sent to all participants after this presentation. And we just hope that you can take a moment to respond, as it helps us plan future events. Thank you for being with us today, and take care.
Thank you. Thanks, everyone.
Thanks.